okay? And when I say a review of everything, we're not going to obviously go into the tremendous detail that we typically do on each particular topic, but we want to kind of do a what we're calling a COVID summer in review, okay? And the goal there is to make sure that we're all cognizant of the high-level things that we need to have in our frontal lobe. What are those things that we need to be thinking about on a daily basis to make sure we are doing our absolute best at protecting our workforce? And we want to make sure as well as we move forward, we can understand by way of reviewing the past where we're heading with COVID. And we'll present some new material, of course, here, but we also want to make sure we cover those high-level points that need to be on the menu, if you would, for everyone moving forward as we continue through this pandemic. And so the format will be the same. Clinical update first, followed by pathology, microbiology review. We'll do the epidemiology, looking at the numbers, followed by the brief preventative strategies. And then finally, we're going to sandwich all the review opportunities here into the workforce strategies. So without further ado, let's talk about something that is obviously familiar to you by this point in time, which is the virus itself and its structural makeup, right? This is a representation of the virus, coronavirus, SARS-CoV-2. And I want you to pay attention to the spike glycoprotein. That's the spike protein that we've talked about numerous times before that has been shown to have mutated 16 times in some literature since its development of the beginning of the pandemic in Wuhan, China. Okay, hold that in your mind because it's important as we continue to talk about where we're heading with things. But what I want to talk about in particular when we are referencing changes to that spike protein and changes to SARS-CoV-2 is that for the first time now, we have a reinfection that's been confirmed out of Wuhan, out of China, but it's an infection that was confirmed by genetic profile, okay? And in particular, the genetic profile of that of some of the proteins, particularly with that spike protein as well, in the virus that was retrieved from this individual. Now, again, this is one case out of obviously millions of cases that we're dealing with at this point in time globally. However, it may be a turning point for us in terms of our understanding of this particular virus and what camp we're putting this virus in regards to long-term immunity and reinfection. So let's dig into it a little bit more. This is a study that is pre-publication. Manuscript has been accepted at this point in Oxford Academic, Clinical Infectious Disease. And this study in particular, as we look at it, examined this particular case, right, of a 33-year-old gentleman who resided in Hong Kong, first encountered SARS-CoV-2 back in March 26th, and they were able to retrieve the virus and examine it back then. He was hospitalized at that point in time, 3 days afterwards, and recovered, in short, from SARS-CoV-2. He had 2 confirmed negative cases, PCR, negative confirmed cases with nasopharyngeal swabs that were taken 24 hours apart. During the second episode, he was asymptomatic, this individual. He had traveled recently from Spain through the United Kingdom, and this episode he was tested again using RT-PCR. Oropharyngeal saliva was taken and posterior oropharyngeal, and this individual was then hospitalized once again, but remained asymptomatic through the course of his second infection. And as he was later discharged from the hospital, the study goes into, and we won't look at the nitty-gritty of all the genetic analysis, but in short, they were able to examine the genome of the first virus from this individual back in March, and the second virus that was retrieved in this second subsequent episode. and looking at GIS aid. That was the body of literature and the non-for-profit effort that I presented to you months ago that looked at the genetic spread, if you would, of the virus from its origination in China throughout the world. They compared the genomics of these two samples and saw a difference, right? A significant difference in both samples. And they concluded that indeed these were two separate strains from two separate lineages of virus. Moreover, and I won't pull up an example of it in this study, but they also looked at, because they had to determine, all right, did this guy just have a colonization of the virus from his previous episode? And the answer was no, because they were able to see a genetic difference between the two. The second question they had to answer was, is this representative of a true infection, or is this just a colonization in the posterior pharynx the second go around? And in fact, they looked at his body's immune response, basically, called a C-reactive protein. That protein usually kicks up only in the setting of an infection. Everybody has that particular protein as a marker. And they saw an increase, a dramatic increase in the C-reactive protein, suggestive of an actual infection, not just a colonization in the mucosal lining of the nares. So again, this is representative of a turning point potentially for us in how we understand COVID and its ability to reinfect, which will obviously change our approach in regards to keeping our workforce safe. So if we continue on that line of understanding, when we talk about, and this is a quote I like from Machiavelli, it says, "Whosoever wishes to foresee the future must consult the past, for human events ever resemble those of preceding times," right? And so what we want to do is take a quick glimpse historically of what we know about similar coronaviruses and see in a short litmus test of, is this one-off study going to open the floodgates for what we may see as a reinfection rate now of COVID-19, or is the historic data pointing away from the fact that reinfection is going to be likely? And so this is a manuscript, the same manuscript that we looked at previously just now, and we want to pull out a particular piece of it, that reinfection is common for seasonal coronaviruses, this study goes on to say. In particular, we want to look at a coronavirus, OC43. There's no significance in terms of memorizing that particular strain. I pointed out just to be a representation of coronaviruses that we've seen previously. And if we look at this particular study that was conducted back in 2005 on OC43 coronavirus, which is in the community, right? We can see that they used a technique called molecular clock, okay? The molecular clock analysis basically does a genetic analysis of a virus and looks historically of where this virus potentially came from as a result of the mutations, tracing back the mutations that occur over time, okay? And what they found is that this particular virus had a genetic sequence, OC43, similar to a bovine from cows, right, virus, that likely had a zoonotic transmission, meaning it came from animals back in 1890, okay? So what we also can glean from this is, obviously, we know this coronavirus, SARS-CoV-2, has arisen most likely from an animal source, namely bats, right? And so likewise, when we are talking about zoonotic transmission of coronaviruses, can they be reinfectious for humans when they cross over? The answer is yes. We've seen this with multiple coronaviruses that have similar histories. And so this particular instance of reinfection is not terribly surprising, unfortunately, right? Our common knowledge was that individuals would have resistance for approximately 90 days. 3 months, right? In this particular case, this individual was tested between the first episode and second episode, approximately 143 days. So it's consistent with what we feared, but hoped would not be the case. And so we'll continue to follow the emergence of similar cases. Time to do the numbers here. So
Dr.
let's look.
It's Karen. Sorry to interrupt, but there's one question related to this study I thought we could just address now because it's pertinent. Normally I don't interrupt. It's specific. Why was he hospitalized when he was without symptoms? If he didn't have any symptoms, how did they know to test him?
So he was actually tested. The hospitalization is part of a protocol, right? A presumptive protocol, that's all. But he was actually tested because he was re-entering his native country. And the protocol for re-entry required testing. So he wasn't tested because he was symptomatic or because he was suspected of having a virus. It was only protocol for screening to help prevent transmission from anyone who may be introducing the virus to his native country. So they were able to track him and then obviously compare historically his first infection in this case. Good question. So where are we now in the US with regard to taking a look back? 2 weeks ago on the 12th, we were at 5 million cases, went up to 5.4 million cases last week, and now we're at 5.7 million cases, 176,000 deaths. If we look at deaths by jurisdiction, we see the number of states that are 5,000 or more deaths continuing to grow, okay? And we want to be mindful of that because obviously that will impact how we respond in our various jurisdictions. If we look at our trend, we've been seeing a positive trend in terms of downward trend of new cases by day, 7 rolling day average here, published by the CDC data. And we're continuing to see that trend from 2 weeks ago to last week to this week. So obviously that's a good sign, good indication that the rates of transmission across the board are decreasing, although still significant, okay? If we look at how we're doing on the macro scale, looking at globally, daily new cases that are confirmed, 7-day rolling average, we were on top of the heap still 2 weeks ago, started to trend downward last week and continue that downward trend this week. In particular, we can see that as we look at our downward trend over the several weeks here, a month's time, India has now surpassed us in terms of number of daily new confirmed cases on the 7-day rolling average. So obviously not news to celebrate, but just news to show and demonstrate that we're continuing to have a downward trend in this particular metric. So if we look at then the number of deaths, we also are seeing a downward trend. This is where we were 2 weeks ago, where we were last week, and where we are today. That trend not being as dramatic as the new cases, daily new confirmed cases, but yet and still a downward trend nonetheless. In terms of the number of our share of positive cases, for the testing that we're conducting, the needle hasn't moved very much. 2 weeks ago where we were, a week ago where we were, and now where we are today. The United States still sitting right under India. And again, this being a representation of how accurately are we articulating the burden of disease in the US. Again, those who are doing really well with this metric are down around 5 and between 5 and 10, obviously between 2 and 5%, excuse me, and we're still around 7 to 8%. So when we talk about prevention, we want to be cognizant of reviewing kind of where we've been, so we can help predict where we're going.
Dr. Harris, you're fading out.
Okay, I'm not sure why I haven't changed my.
I don't know.
Yeah. So
we've tried everything. Anyway, just letting you know.
Apologies here. I'll put in for a new laptop. How about for that one? All right. So as we talk about prevention here, we want to look to what's happening around the US, right? We have Florida, one of the hardest hit states here recently, focused in on prevention. Areas in South Florida, the mayor there, reopening, getting ready to reopen restaurants for indoor dining. And we have the looming potential opening of the stadium with 12 to 13,000 people expected to be there. Still representative of a small capacity of the entire stadium, but this is what's happening around the country. And so we want to, as our workers may be amongst those who are participating in these type of social events, we want to be cognizant of what our program is in the workplace and want to be extremely cautious to know that we are doing everything we can to make sure we're mitigating risk. So let's do a quick review. Now, we're not going to do it quiz style, but that would be fun if we could. So we'll start with just the basics of where we began here months ago back in March. We know the virus originated in China from bats, very likely, and we know that this virus causes a pneumonia type picture. We know that this virus has mutated over time. There are now multiple strains of the virus that has been documented, well documented in literature, and we continue to track through the non-for-profit organization I mentioned earlier. And we can see how that's impacting, obviously, our potential for a vaccine. Remember that spike protein is what mutates and can cause a inefficiency of any vaccine in regards to immunity for humans. When we look at genetic mutations, that's that S protein we're talking about, right? We reviewed genetic drift and genetic shift being those things that happen to viruses normally, right? Genetic drift being small mutations, genetic shift being larger mutations. We know this occurs with the flu. That's why we deal with the flu year over year, and that's why we have to use different vaccines year over year. When we talk about then the relevance of testing, we want to make sure we still hold in mind, right, the optimal time to test in regards to why, right? We want to make sure we're capturing those asymptomatic individuals who may present threats for transmission and may not have this immune response that those who become symptomatic demonstrate, okay? And the basics, the very basics of our process to help prevent these symptomatic individuals begins with the screening protocols, right? Make sure you're doing some type of daily screen. At this point, if not 100%, we should be close to it, of employers doing daily screening of their workforce across the board, okay? And we're now to the point where it's data management, right, and trend analysis that's important to try to understand from the screening that's occurring across the board. And we can talk subsequently about those strategies and understanding the data that we're seeing on the clinical side. And then stratifying the risk, making sure we can put individuals in the appropriate level of triage so that you're not inappropriately causing someone with a common cold potentially to be out longer than they should, or someone with pre-existing conditions to be out at all versus having to quarantine those who don't have pre-existing conditions as a cause of their symptoms. The number, the second base, if you would, in terms of the program being looking at, is it appropriate for you to be doing baseline testing to reopen facilities that aren't reopened currently as we go across the state to state reopening. Looking at your risk appraisal, and this is going to become more prominent in the future here as we talk about dealing with COVID now. If you listen to Tony Fauci a week or two ago said, we may never get rid of COVID-19, right, ever. Even with a vaccine in place, the potential for it to exist because of its level of infectiousness is very possible, right? And as we talk about even a herd immunity scenario where we have 60 to 70% of the population need to be immune, to COVID-19 in order to hopefully protect others, we may never reach those levels because now the potential for reinfection is a play, right? And so as we assess risk on an ongoing basis, we have to make sure that COVID risk appraisal is in place so that we're articulating risk for each geographic appropriately and applying the appropriate preventative steps. If we're overdoing it across the board, it may be too costly. It may cause too much absenteeism. If we're under prescriptive in that analysis, then we may not be protective enough to help prevent those individuals from transmitting at work. The scheduled testing, we're doing that across the board. At some point, we believe each employer will have encountered some type of scheduled test because the workforce, in terms of getting back to work and maintaining protection, if we harken back to our models, right, of what prevention looks like and how frequently we need to test on a scheduled basis, we know the more frequent the testing, the higher the level of prevention in workplace transmission. Now, albeit though, we've only had one employer that has done a weekly test on workers, we know that testing is going to be fundamental. And we can talk subsequently in talks maybe in our next week's talk about what CDC has just recommended against testing. And we can talk about the backlash from the clinical community as a result of those recommendations. And again, we won't touch on it today. We won't have enough time, but certainly it's important to discuss the ramifications of that change in recommendation. COVID surveillance, again, all part of the approach to helping keep the workers safe in the workplace. How strong is your contact tracing? At this point, we realize and recognize many of our employers cases have outpaced or outstripped the capabilities of in-house HR or in-house EHS to do contact tracing at scale, right? And so we want to make sure that you have the right process in place, that you have the right partnership in your clinical communities to do contact tracing from now until this time next year. Very likely, again, we'll be dealing with COVID until then. How strong is your case investigation? And this is the first steps to doing a causal analysis in regards to workplace transmission for a particular case, right? So making sure this is in place and that it's fortified with the backing of clinical analysis, as you see here in the downward depicted graphic here. And then again, when we're talking about setting thresholds for our application of solutions and preventative measures, those thresholds should be based on local rates of transmission, right? If it's not, then again, you may be inappropriately applying resources where they're not giving you the biggest bang for your buck, the greatest ROI. So be cognizant of having these thresholds in place and being able to apply appropriately the level of prevention when it comes to testing and when it comes to other measures of intervention. When we talk about then, actually I'll skip over this. I already spoke to this in that previous slide as well. So when we talk about kind of the next big, maybe it's not the biggest thing, but it certainly is something that's being mandated by states, which is, if we look at Oregon, if we look at Virginia and other states, they're mandating training for employees in those states, training on COVID prevention. And they're also mandating not just training in for the general workforce, but they're mandating training for specific individuals to be the employee leadership when it comes to COVID. In a sense, a COVID compliance officer, if you would, or a COVID champion. And so we want to make sure you've addressed appropriately what is your training for your general workforce and what measures are you taking to train specific individuals about how to help others as they deal with COVID in the general workforce. Because again, it'll likely be something that is promulgated in your state that you have to have in place as part of your OSHA now, state OSHA mandated program. These are general topics, obviously, that you can have in your training materials. We want to share these with you so that you can put them in place, from mask wearing to hand washing to disinfecting, all obviously important to zero in on in your training materials. And again, in some areas they're calling it COVID compliance officer, COVID champion, whatever you term it. It's going to be necessary to delineate those individuals in the workforce who are responsible for helping with conforming to those protocols and to those protective measures that are now being held up by legislation. When we talk about then compliance and protection, we reviewed previously what are the issues with EEOC and ADA, right? What are those health impacts, pre-existing conditions that you need to consider, that you need to have a process in place to deal with? When we can't ask specific questions as employers, who do we go to, right? What's your partnership for addressing those issues and determining the impact from a COVID standpoint to a particular individual or the workforce in general? When you have a sick contact or a sick household member transmission, how are you assessing the risk, right? And what are those gray areas that we need to be concerned about as we address questions to the affected individuals about their family members? And then finally, the return to work process, how do we begin to ascertain who's safe to come back based on existing conditions that may affect an individual's return to work and timeliness for return to work outside of the general CDC recommendations because of those pre-existing conditions and the impact to how they experience COVID and recover thereof. And then the general return to work considerations clinically, history and duration, onset, severity. We want to talk about the infectiousness, right, of that particular individual based upon their proximity to other workers. All those considerations in your return to work program need to be hard, fast in place so that as we continue to deal with this throughout the months to come, there's no question as to the timeliness and the appropriateness of getting people back to work. And then finally, as we deal with, on a large scale, absenteeism as a result of COVID, being affected by COVID, doing the daily screen, the remaining at home, the COVID testing, the local testing, and the return to work protocols, right? We want to make sure we have in place something to deal with those individuals who may be abusing the system, who may be staying out inappropriately, who may be taking advantage, as one of our employers put it, taking a COVID vacation multiple times, right? And so having a fitness for duty program in place is going to be key to help minimize these individuals from gaming the system. I want to leave you with a bit of hope here, right? We know we've talked about in the past an update to a vaccine coming into play. We talked about the Oxford vaccine clinical trial that received funding, $1.2 billion from the federal government, has been in the UK and Europe and in South America, and having good success. We want to leave you with a picture of what does the current vaccine trial update look like. And as we have looked at it in the past, there historically have only been 2 vaccines in that phase 2, phase 3 clinical trial. But as we see and stand today, we have now 7 that are in either phase 2/phase 3 or are squarely in that phase 3 clinical trial. And recall, phase 3 is the final trial before approval. So again, we're seeing a lot of potential, hopefully here for a vaccine, if not by the end of the year, to be early next year introduced. But again, with that wrinkle in play of now reinfection being possible, potentially possible at scale, the effectiveness of this vaccine may be compromised in the long term, which means we may be dealing with COVID, like I said, for a very long time, if not from here on out. And so we want to make sure we continue to provide up-to-date, accurate information for programs that need to be in place to help protect your workforce. That is the summer review. Thank you for participating, and we'll open it up to a few questions as we have remaining time here.
Thanks, Dr. Harris. That was a whirlwind trip back through the past couple months. We have one question about the Hong Kong patient. The question is the thinking that perhaps the reason he didn't have symptoms the second time was that he had COVID-19 or SARS-CoV-2 infection already once before?
That is absolutely correct in the thinking and rationale clinically behind why he was asymptomatic during his second episode of COVID-19 infection. And drawing from that, there is literature back from 2003 and 2005 that looked at immunity of those individuals from SARS-CoV-1. And fast forward to literature from today, there was a proposed 85% cross immunity from those individuals who had SARS-CoV-2 back in 2003 to SARS-CoV-1 back in 2003 to SARS-CoV-2 now. Put more succinctly, if you had SARS back then, you were likely to be immune to the tune of 85% to SARS-CoV, this episode of COVID. And very likely that was the case for this individual.
Okay, well, that's good news anyway. Jumping ahead to your last slide regarding the vaccine. And I have this question too, because I haven't read anything about it, but what's the plan to distribute the vaccine once one is approved? For example, would there be a hierarchy established of those in greatest need, and it would be scaled? Or, what do you think is likely to happen with distribution?
Sure. So we don't have in the clinical community a lot of information yet as to how the government is going to roll out and distribute a vaccine when it becomes publicly available. However, we know that first and foremost that the vaccine is going to go to military, right? Most likely first, as we are seeing in China that they've approved the vaccine going to their military, same in one or two other countries. And then to those that are most vulnerable, right? Hospitals, to individuals who are at risk, and then to the individuals who are otherwise healthy will likely be last in line for distribution of the vaccine. But details have not been widely published or anything as to the particulars. Rest assured, though, the CDC is already planning, FDA is already planning, as are we as an healthcare organization, planning how we will distribute vaccines when available to our clients.
Okay, I know you said you want to address the CDC testing guidelines next week, possibly as our topic, but there's one question about it. Can you comment on the change in CDC guidelines on testing of people who have had contact but are not symptomatic?
Sure. So this recommendation has come at a time where the general clinical wisdom is that those individuals who are asymptomatic that have had close contact, meaning 6 feet for 15 minutes or longer by CDC guidelines, should be tested, right? These are the people that we want to know quickly, are you potentially transmitting, have the potential to transmit the virus to other individuals? And this is also the sentiments of not just myself, but also other leading epidemiologists and infectious control experts, right? And so there is a backlash currently regarding these recommendations and why these recommendations have come out at this point in time. And so obviously many can speculate as to why that is. I have yet to understand myself clinically what the advantage of these recommendations will provide us in regards to helping prevent illness. If we look at and recall the clinical models, predictive models on decreasing transmission, particularly in the workplace, the factor that saw the best result was the frequency of testing. And so to suggest now that individuals may not need to be tested at all goes against, again, what we've seen in these type of models and more understanding is necessary as to why the CDC has made these recommendations.
Okay, I think that would be a great topic for future webinar. Now we have a few questions regarding flu season coming up. The first one is, can you address the efficacy of receiving a flu vaccine during the pandemic? I recently read that flu vaccine can actually present an increased risk of COVID infection by reducing non-natural immunity.
We did present on this about a week or two ago, and the data from the effect of flu vaccinations at scale on COVID-19, the data came from Brazil. Brazil having a very robust flu vaccination nationwide effort since 1999, looked at tens of thousands of individuals who were vaccinated both with the flu vaccine, trivalent flu vaccine of 2019 and the trivalent flu vaccine of 2020. And what they saw was an actual reduction in mortality if those individuals who were vaccinated received the 2020 dose. And so the data would suggest that the flu vaccine can be actually protective for severity and mortality of COVID impact, and not and I have not seen any data to suggest that individuals retrospectively have experienced an increased risk for COVID-19 as a result of flu vaccinations.
Okay, we had a question similar to this before with regard to flu. With flu and cold season coming, how will we know if someone should be at work because it's just a cold, or if they need to be home with the flu or COVID? And this kind of relates to another question about screening, because someone was asking, why is there still an emphasis placed on temperature when temperature is just one symptom, and often people who are contagious don't present with temperature?
Sure. So to address the last part of that question first, temperature screening is and continues to be necessary but not sufficient, right? Because an individual may be most infectious during the time they're febrile, making sure those individuals do not cross the threshold of your facility is key, and temperature screening can be effective for that prevention. In terms of the first part of that question, looking at then individuals and their preventative, excuse me, go ahead and repeat the first part of that just to make sure I understand it correctly here. I kind of lost that train.
Okay, now I've scrolled back down. Let's see, hang on a sec. With flu and cold season coming, how will we know if someone should be at work because it's just a cold, or if they need to be home with the flu or COVID?
Yes. Okay. So as far as the preventative approach for that, that scenario, and what we're anticipating is, yes, it will be very difficult to understand from an automated standpoint, if you would, a screening standpoint. Does somebody have COVID, or do they have the flu? What we are putting in place are protocols so that your partnership with your clinician can help make that determination, as well as potential access to testing, right? There are on the horizon and have hit the market on a dual test that's testing for coronavirus as well as the flu. Even minus that dual test, testing for the flu avidly in that scenario may rule out that you have the flu and may be more likely to have coronavirus. Obviously, the impact being how long you should be out in quarantining or in isolation. So those methodologies will be the topic of subsequent talks here in the next week or two.
Okay, I'm really sorry we're running out of time. We really only have time for one more question, and we have quite a few remaining. So we will answer those in writing for those of you who don't get your questions asked now live. The last question is, have you seen the recent article about how one strain of COVID-19 caused a large number of cases in a biotech convention in Boston? Are some strains that much more contagious than others?
Yes, I have peripherally seen that article. I haven't dug into it deeply, but we know it's not so much about the strain itself as it is about the events. I believe about 2 months ago, we presented on a concept called super spreaders. And super spreaders were at first articulating the individual as well as the potential strain that the individual had that caused the broad transmission to occur. What we know now is that it's less the strain and individual in as much as it is the event and the circumstance of the event that caused the broad transmission. Obviously, in a convention, you have individuals not social distancing well. You have opportunity for a lot of face-to-face conversation, which increases the risk of transmission. Similarly, we looked at an instance of super spreading event such as church and being in the choir and singing, right? We've certainly seen those episodes occur many times over. So it's more about the event being a super spreading event versus the genetics and makeup of the virus itself.
Okay, we're out of time. I just want to tell John, who's asking about gators, that he should look at our frequently asked questions on masks, because I added a little section about that subsequent study that followed the Duke study that tested gators on mannequins. So there's a little information there if he wants to dig into that. So that concludes our session for today, everyone. Thanks so much for joining us. We'll see you next week. Take care, wear your masks, and be safe.
Thanks, everyone. Be safe. See you same time next week. Bye-bye.